Welcome to Acute Conversations, the official podcast of APT Acute Care, where we share engaging conversations about acute care physical therapy so you can connect to your profession. I'm Lior Arguelles, and in today's episode, my co-host is Danny Young, hailing from the University of Nevada, Las Vegas. Today's guests are two new grads from UIC's DPT program, Brandt and Fiona Kearns. They share their experiences on their acute care clinical rotations, the impact it had on career plans post-graduation, and the amazing insights they learned on the value that acute care physical therapy brings to patients in difficult times. Let's welcome our guests. Welcome to the Acute Conversations podcast. Today, I have a co-host with me, Danny Young, who's coming from Las Vegas. Thank you, Danny, for joining me today for this episode.
Great to be here. Thanks for having me.
Excellent. I also have two students that are going to be graduating within the next month from the University of Illinois at Chicago. We have Fiona Kearns and Brandt. Thank you so much for joining us here today.
Thank you. Thanks for having us.
You're welcome. So the reason that we wanted to have you on the podcast today is because your final clinical rotation, though, that you just finished literally about a month ago, was in the acute care setting. And so I thought it would be great for our audience to hear what that experience was like, because the novelty, it being a 2-to-1 rotation, also it being a terminal rotation, and also it was at a very, very busy medical center over at the University of Illinois Hospital. So before we jump into that, though, let's just get a little bit of background of who you are, where you're from, and how you got interested into PT. Why don't we start off with Hannah?
I'm Hannah. I'm from the northern suburbs of Chicago. I have lived here my whole life. Now I live in the city and I'm going to school at UIC. Like Leo said, it's our third year, so we're almost at graduation, which is very exciting. I got interested in PT just because I didn't want to follow in anyone in my family's footsteps, which is like all business sided. I'm very just independent and want my own path. So I was like, what could I do that, I don't know, would be interesting, fulfilling, and that's not sitting behind a desk all day, which is like what my dad and sister do. So I was just kind of thinking about things in healthcare and ways to help people and just feel fulfilled at the end of the day, and just kind of had heard about PT during the college application process and went into college with that degree and never changed out of it.
Very cool. Awesome. Yeah. Welcome. Fiona.
I'm Fiona Kearns. I'm from Chicago, actually grew up on the north side up by O'Hare, lived there my whole life. I live in more downtown in the city now. I have some roommates, some girls I went to high school with. Like Hannah said, third year students at UIC. We're 2 weeks out from graduation. It's so crazy. And then I got into PT because I kind of always knew I wanted to go into healthcare, but I wasn't totally sure what that was going to look like. And kind of getting closer to senior year of college, just thinking about the thought of going to med school and how long residency is. And that just really did not appeal to me. And I really like the aspect of PT of the length of time you get to spend with your patients and you really get to know them while you work with them. And I really appreciate that about PT. So that's kind of how I got to that.
Were you able to spend plenty of time with them on the acute care settings? Fast, right?
We had some, though, were definitely some long-term ones. Definitely had for a couple of weeks while we were there.
Very cool. Very cool. Danny, what questions do you have for these students? And I promise you, I didn't pay them anything to come onto the show. I didn't bribe them. So they hear their own free volition, and I'll be honest with you.
There's no extra credit points or anything.
That's right. That's right.
Can attest to that.
One of the things that I see in students as they finish their second year, before they go out on their long-term clinicals, is they start to get just burnout on school. What was your experience with classes, and how did you deal with that in order to maintain momentum going into this clinical?
I can start. Yeah, definitely agree with the burnout. I think it's just going for 5 semesters straight. And obviously you have your little breaks in there, but there isn't really a lot of time to ramp down before you have to ramp back up for your classes to start again. I will say I feel like the way that the curriculum, at least at UIC, is broken up helps because I don't feel like that semester right before we went on clinicals was quite as tough as some of the other semesters that we had. So I think that kind of helped. Plus, and Hannah can speak to this too, we did our like site visits that we had kind of built into the program that semester, which kind of helped with like dipping toes into what the actual clinical experience was going to be like, which I think keeps you eager and like excited for what's to come without totally like flattening you and making you too tired to participate.
Yeah, I agree. I like the way UIC does it. We're kind of front loading classes and then your whole last year is clinical. But I have some friends in different programs who kind of have like 1 or 2 semesters of classes and then they go on to clinical, then they come back, which I think that would be difficult, just like not knowing everything going into a clinical, not having all your coursework. So I think while burnout is real, I do like appreciate UIC for kind of giving us every piece of knowledge we could need to encounter things on our clinical. I would say a way I kind of dealt with it and try to like minimize the burnout as much as possible is just like trying to find balance where if we had a long day of classes from like 8 to 4, I would give myself like an hour to either like do nothing and lay on my couch when I got home or like go to the gym or just find ways to like break up my day so I don't feel that like PT is the only thing that's encompassing my mind, because I do feel like you have to acknowledge the burnout to get through it. So kind of finding ways to kind of minimize it as much as you can. Like if I go home and see my parents for the weekend and just kind of like get out of my bubble of the city and school, that kind of helps too. Are kind of ways that I have found to kind of get around.
Yeah, I love those ideas. Those are great. Leo, did you have a question or comment?
Yes, then I wanted to ask you, because you're over at University of Nevada, Las Vegas, how does your program kind of work in terms of how they set up the clinicals, and what have you seen in terms of the students, how they manage burnout situations?
Yeah, well, it seems to be a universal challenge, at least based on Fiona and Anna's comments. And the 18 years that I've been working with students here, I haven't had a group that didn't suffer from some of that. When it comes to our curricular program, it sounds like we have a similar setup in that most of the didactic work is before these long-term clinical rotations. And so 2 years of didactics and then clinicals. But we do have a couple of things in those first 2 years that I think also help. So in the first, after the first full year of coursework, we do have a 4-week clinical. The students who are doing that have had some of their basic orthopedic classes. And so that 4-week clinical has to be an outpatient orthopedic experience because that's the only thing we've kind of prepared them to do. And then in their second year, we have quite a few ICE experiences, integrated clinical experiences, where they get to go and do some shadowing and depending on the site, some intervention as well with the patients or clients they're seeing in the settings that they are learning about at the time. So right now I'm teaching cardiopulmonary and acute care. The students get to go to some hospitals and subacute rehab facilities and to see the types of patients that we're learning about in that class. In my class, we have 5 different sites that they go to over the course of the semester for a half a day. And so it's a pretty good exposure to the things that they are hoping to go out and practice then in their third year when they're full-time on clinicals for that whole year.
And so, Fiona and Hannah, what was your experience with, from what I understand, your first experience with acute care was during the ICE visits over at UIC, correct?
Yeah.
And so what did you think with that being the first time of actually working with patients in that setting? The majority of students that I know don't even know that acute care physical therapy even exists. They're like, what? We're not going to go work with athletes and soccer players over at the outpatient clinic? Like, what are we supposed to be doing over here in the hospital? So tell me about that experience.
Yeah, I would say I remember from myself and like talking with friends about it too. Like whoever had the first visit, they would come back and we were like, how was it? Like, was it scary? Were you nervous? Because I feel like a lot of people went into the acute care ICE visits, just like a lot of nerves, not knowing what to expect. Like, I feel like growing up, if you know someone who's sick and they're in a hospital, it can be like have a scary connotation with it. So definitely, I think it's very good we get early exposure to it, especially because for me at least, when I was applying to PT schools was during COVID. So a lot of shadowing hours in hospitals was not available just because of COVID experiences. So like while I would have liked to have experience before coming into PT school in that setting, I didn't get any. So while I was like eager and excited to see it, it does come with a lot of nerves. Just like you hear about all the lines in class. And if you pull this line out, like bad things could happen. So I think like we have to be prepared to realize the extent of how sick some of these patients that we work with are, but then it makes walking into the room a little bit added nerves. So I appreciated the experiences a lot, but yeah, I feel like there was definitely just a lot of nerves because it's not just like, oh, this athlete who is so strong and like is used to running all day. Like I'm it's a lot less, I think, on you, like a student physical therapist, compared to someone who's sick and in the hospital.
I actually had like a volunteer gig at Rush the summer between my junior and senior year of college, like in acute care, but it was mostly on the ortho floor. And the way that they do it there is like, as long as they can, they bring the ortho patients to this like gym that they have. So it was it was very different from like what my experience at UI Health was. So I did at least have like some context, but obviously like ortho patients, it's a lot less lines. Like they've got some ice packs and like maybe a wound vac, but not really a whole lot else. So the ice visits were obviously like very different from that experience. And I had some rough ice visits. My first ice visit, we had to screen out a DVT for the patient and it didn't get screened out. It got pulled in. So that ice visit didn't go super well for the first time. And then my second ice visit experience, my patient had 3 seizures while we were in the room with him. And obviously, like that can happen in the acute care setting. It's not out of the question, but that was just kind of like a big, like, welcome to acute care for sure. Like this is what it's like to be here. So definitely like high paced, a lot of like adrenaline from those experiences, but definitely learned a lot and I really enjoyed them. So
I was in related to this question that you asked, Leah, which I was also wondering about. I'm curious what happened to your career plans or expectations after going on this rotation. Fiona, you said some experience in the hospital, so that wasn't totally new, but Anna, you said this was much more of a new environment for you. After then going and doing a full-time clinical, what impact did that have on your thoughts about your future career, where you might want to work? Did it reinforce your plans from before, or did it make you think about other options?
It drew me in, and I really like acute care, and that's where I'll be applying into. I enjoy outpatient ortho, and like that's kind of what my experience has been coming into PT school, but I liked it, but I was never like, yes, this is where I can see myself for 30 plus years, like in my future career. But also, I feel like I didn't know a ton about the other settings going into PT school just because you're driving down the street and you see Athletico, you see IV therapy, you see like all of the outpatient clinics that it's just what's in your mind. So, kind of getting that exposure, I'm like, whoa, like if this is what I can do every day, like I can be the first person after someone has a stroke to get them out of bed. Like those are the things that were so rewarding to me on my clinical, and like seeing the family members like crying because I sat their dad up for the first time in 2 months maybe. That's like when I had those moments that it's like, wow, this is so cool that like I can be the one to do this and have such an effect on this person's life. So it ended up kind of like confirming and reaffirming the acute care setting for me. I think it is very rewarding, and just I love the fast pace of a hospital. Like I don't like sitting around, hence why I didn't choose the business career that my dad had, that sitting behind a desk. I like to be moving and like, okay, this patient doesn't want to see me or is in x-ray right now. Like, let me go find someone else to see. And kind of having the flexibility of here's your list for the day. It's 20 patients. Like make it work somehow in the hours that you're at work. So I also really like that aspect of it. So those are kind of like the 2 main points that had me choose acute care for my future career. Yeah.
Yeah. How about you, Fiona?
yeah, I had the acute care experience and some outpatient ortho experience coming in to PT school, and I really wasn't sure which way I was gonna want to go, but kind of going into clinicals, I had enjoyed like our acute care stuff in school, and I thought that was kind of more so what I enjoyed. And I was nervous going into the clinical, I think just because I was worried that maybe it wasn't going to be what I wanted it to be, but it was definitely everything I wanted it to be and more. Definitely confirmed like acute care is where I want to be, definitely like the area I want to work in. And UI health in general, I really enjoyed. Like it's a very complex patient population. There's a lot of other factors, psychosocial stuff, which makes it a challenge in its own way. But I think Hannah and I both would say that we learned a lot from that experience. We got to work with so many other people, so many like complex cases, and it was a really great learning experience. Definitely confirmed that's where I want to be in the future.
Well, sounds like people to have on the Acute Care podcast.
Yeah, exactly. I would say I think we really have to thank your instructors at the University of Illinois that motivated you, that taught you about the setting. That must have been fantastic instructors that really kind of put that seed into your brain.
Definitely.
Danny, I've got a question for you. And I don't know if there's any metrics that have measured this. I've always wondered, what are the number of PT students that are applying into PT programs that maybe have an inclination more towards like outpatient or that are not acute care? And then how many end up actually in an acute care setting? Anecdotally, I'd feel that less than 5% know what acute care is or have any interest in it. But I'm seeing within the past couple of years, I think Kirby Mayer down in Kentucky might have looked at this, and it might not have just been acute care. It might have been acute care and like all inpatient settings, but there's been a rise in the number of students that after graduation, they end up in an inpatient, whether it's subacute, inpatient rehab, or acute care settings. I don't know.
I don't know of research on that. I don't have that in my head. But just like you said, anecdotally with the students that come through our program, I definitely see that when students are exposed to those settings, it definitely influences how they feel and think about them.
Yeah.
And one of the things I consistently hear, and let me know if this is true for you folks, the opportunity to work one-on-one with patients is one of the things that people find appealing in inpatient settings. In outpatient settings, you have to do a lot more dovetailing of patients. You have several patients in the clinic at the same time you have to manage. You don't get a lot of one-on-one time with them, and they often don't need as much hands-on stuff. They need exercises, and you tell them what to do. And as long as they're doing it well, they don't need a lot of you to physically be involved with them. Whereas on the inpatient side, whether it's a hospital or a subacute facility, then you end up being one-on-one with people and they physically need you involved with them. And that physical contact seems to be appealing to some people as well.
Mm-hmm.
And as you know, Leo, that made me think of one of the questions I had as you guys were talking about how impactful those clinical rotations were for you. There's a lot of programs struggling to find acute hospital rotations for their students. And maybe you can, Leo, you can talk about that from your program. Is that an issue for you folks? And then for Fiona and Hannah, what do you think about programs that aren't able to offer acute care clinical experiences to their students, get full-time rotations because there's just not hospitals nearby that can do it for them?
You know, Danny, you read my mind, because this is my challenge right now, especially for the summer, but even for the summer, just for the rest of 2025, like usually in March is when we send out the March mailings where we let institutions know when we're putting our request in for the next year, but there's just a low number of available acute care sites. And I feel that maybe because of COVID, and there was that dip because of COVID, and it never has really kind of come back up. And it's to the point where some places, you're right, they like acute care is not a required part of the rotation. There might be some other form that or way that they fulfill those CAPT requirements, but there's just low numbers. So I'll pause right there, because Hannah, Fiona, you went through the whole wish list process, trying to meet CAPT requirements, 6 weeks of ortho, 6 weeks of neurocomplex, and ending up in this very last rotation, but then also gaining so much from it, and now actually changing the trajectory of your career path. So I'd love to hear your perspective about that.
Yeah, I think that would be really tough. Like, obviously, if it's an issue, like, there's only so much you can do about it as the institution and what you can offer. But I think it's such a great learning experience, and kind of as we've all touched on, it's a really hard one to be exposed to in the first place. And if you're not exposed to it, I think it sounds really scary and not like something that somebody would want to do. And I do think it would be really hard to graduate without that experience and then start applying for jobs and want to apply for that type of position without having had any experience in it. So I definitely think that would be a hard position to be in, to try and like grow this part of PT.
Yeah, I agree. I think that it could be a disservice to like that chunk of students who doesn't know what they want to do and are like using their clinicals as a way to kind of filter out yes or no for different settings, which is kind of what I did. My first one was outpatient ortho. I was like, it was a great clinical, great experience, but I was like, yeah, I don't think that's for me. And then my second one was outpatient neuro, which I was like, okay, I think I'm getting closer. Like, I really like the neuro population, but I found the outpatient setting with neuro population kind of difficult at times to work with because you're in just like the chronic stages of their diseases and diagnoses, which can be kind of challenging, I think, at times. And so for my third placement through the wish list process, I got another outpatient neuro clinical, which I was excited about because I was like, okay, I do really like this population and it could help me in the future get a job in a neuro setting of some sort. But I was really looking for that acute care setting. So I actually worked with Dr. Leo and another student in my cohort and switched clinical sites. And I am very grateful that I was able to kind of work with Dr. Leo and the other student in my class to make that happen. And we both ended up in places that we wanted to be. So that worked out really well. But for me personally, like I don't know where I would be if I didn't get that acute care setting. Like Fiona said, like I would probably be applying to jobs still in the acute care setting because it still is what I had an inkling towards what I would like, but I wouldn't have had 12 weeks of experience in it, which I think could be to my disservice starting a job or even my patient's disservice, kind of starting from ground zero instead of having 3 months of patient care.
And sorry to interrupt you, Hannah. I totally agree. And I think it's hard for students because Leo, you even said so many students come in with a sports ortho background and that's what they envision themselves doing. And it's not until they get some exposure to the hospital that they realize how much they like it and how much they want to do that. And I think we would find ourselves in a real shortage situation of clinicians who are doing acute care practice if we didn't allow them to get some exposure because they just wouldn't choose it. And so it's a significant challenge. And I think we have to get creative as education programs and how we help expose students to the opportunities and some of the benefits that you just highlighted that are there. So I love that.
You know, Danny, the thing that I'm noticing too, and I worked last weekend at the hospital and I talked to an OT that I'm really good friends with, and she runs the OT student program. And I was just asking her how things are going. And she had said that a lot of the employees are just burnt out and they don't feel like they want to take on a student. That's one, just in terms of the workload of the employees in the hospital. But then the other thing is that she said prior experiences with students have left a really bad kind of taste in their mouth of students with a lot of entitlement and just like one bad experience. And again, I'm not saying all students or all students in this generation, but one tough experience, despite the fact that you've had like great students, can really set things off. And I still don't feel that there's a lot of acute care PTs. So if you're listening out there, please, we would love to send more students to these acute care rotations, but we need the availability, right? Like I wish I can make it mandatory that every student has at least part of, an acute care rotation, even if it's just for half of the rotation, right? Like out of the 12 weeks, maybe 6 weeks. But I can't make that happen unless I have the infrastructure to support that. And in order for that to happen, I need the CI. So CI's out there. Part of it too, I think it's important to let Hannah, my eyes also bugged out too when so you had 20 patients a day, but I'm assuming that's a shared list between you and Fiona, right? Okay.
Towards the end, we were splitting the floor. And so like we would kind of go in and our CIs would assign us like, here's half the patients on the floor for Fiona, here's for you, Hannah. And then we would have to like triage like who's stable enough to be seen, who are we going to give to the PTAs on the floor. So they like kind of threw us into like what they do when they walk in, like here's your floor. Who are you going to see today? Like who is your priority? Who could maybe,
So I love that young energy that you all can bring into a new environment. And so hopefully there's CIs that are out there that are gonna, have these opportunities, and also just job opportunities. If there's places that are looking for young new talent, there's plenty that are coming out and coming from very strong programs and having great clinical experiences where they got these skills that have really added value to what we do in a hospital setting.
So the concept of burnout, you're saying, isn't restricted to second year DPT students. It happens to clinicians too.
Yes, definitely. At least, and I also feel it's contagious. You like walking, Danny, you ever walked into a floor and you students probably ever see, like, you walk into the floor, you're like, what is going on? You're like angry. You're like, was there a code this morning? Did something happen? Did a doctor come in? So, it's tough, but yeah, that burnout happens, and it's contagious, unfortunately. But also is that optimism too, and that's why I think there's hope. We've got these students that are coming in that have optimism. I love when I hear these students that are coming in and like they've got these ideas, fresh new ideas, and we want to try this, we want to implement this program. It's great. Here's your platform. Let's see what we can do.
I was thinking that the reason that you have some of those CIs who are reluctant to take students is because they didn't have Fiona and Hannah. And if they had, they would want more.
Right. Absolutely. Yes.
Yeah. What did you see any of the therapists at the hospital, Fiona and Hannah, who were struggling with that? What do you think is going on there? And what do you think we need to do as a profession to try and combat that issue of burnout in practice?
I mean, I don't know if we necessarily, maybe because we were students and they were trying to like not show us that side of it necessarily in the day. But I mean, I think sometimes
you from the dark side of the ground.
But I do think like we worked alongside a lot of different OTs because we bounced to a lot of different floors while we were at UI Health. So we got to work with a lot of different OTs. And I mean, the monotony of the day to day definitely like does get to you. And like we were on the neuro ICU and like step down unit for about 6 weeks. And I mean, obviously there's a lot of like good stories, a lot of patients that make a lot of progress, but there's a lot of stuff that doesn't go right. And like I kind of mentioned before, UI Health, a lot of those patients have a lot of psychosocial stuff, a lot of uninsured patients, things like that. And that stuff is really heavy. And then just to have to kind of turn around from like a conversation that doesn't really go well to then have to go work with another patient. Like I can definitely see how like the burnout catches up really quick, just trying to be there, be present, be positive for your patients, but you have all this other stuff going on in the background for sure.
I think also by talking to RCIs, just kind of about like future and jobs too, they were saying something they really like about UIH that kind of helps with that is that every like 6 or 8 weeks, they're switching floors. So they're not hired onto a certain floor, seeing like the same diagnoses for their whole career, however long. So they said that really helps just because like you can only see so many XYZ diagnoses before it just starts to feel like redundant and that you're like not using as much maybe clinical reasoning from patient to patient by just seeing the same things. So I think they said like switching floors and kind of like getting a new refresh of nurses, working with a different OT and just kind of like staff in general. They said that they felt that really helps them.
As you were talking, and Leo, I know we're about ready to go into our rapid response. Just a quick comment about that for my own perspective on it. One of my favorite quotes comes from Viktor Frankl's book, Man's Search for Meaning.
Mm-hmm.
He says, "He who has a why to live for can bear almost any how."
Yep.
And I think one of the problems that we have is that we aren't finding enough meaning in what we're doing. We think what we need is ease and happiness in our jobs. And instead, I think what we need is to recognize how meaningful what we're doing is. And if we focus on the meaning in what's happening, I think it will combat a lot of the burnout that we see. Hannah, you talked about this. You're excited to go into acute care because you get to be the one to help people. And I can see the energy that brought to you. And I think what happens to therapists is they lose sight of the meaning in what they're doing. And maybe it's because they're not doing the things that are meaningful. Maybe we're spending too much time on low value consults and we're not spending enough time doing things that really add value. Maybe instead of not taking students, the students creates meaning because I'm helping the next generation approach. It's not an extra thing that I have to do. It's an opportunity to add meaning to my work. And that, I think, is a way to combat some of the burnout that we see. It's not the only part of the solution. There's lots of other thoughts that I have, but I appreciate the things you said that helped me to think of that quote that I think can help.
Yeah.
Danny, I smell the seeds of another podcast episode that we're gonna have to record, because I love what you said in terms of the value in the nets, but how do we combat that in terms of, are we seeing, in terms of the value that we bring, are we seeing the right patients at the right time, right?
Yep.
And are we bringing up value, to us individually, to the profession, to the patients, to the hospital, so that everyone walks away with a positive experience? Because obviously, if there's consults that we feel that we're not, we've got X amount of patients, how do we triage and say what's going to be the biggest bang for our buck, right? Who are the patients that are going to benefit the most, which I know that there's a lot of research and developing research, which again, Danny, I feel that I'd love to hear your thoughts on that, but for another episode.
Yeah. Well, you're speaking my love language, so I'm up.
Very cool.
Attention members. APT Acute Care is currently seeking nominations for the 2026 elections. Open positions include Vice President, Treasurer, Practice Chair, Membership Chair, Nominating Committee Member, Residency and Fellowship SIG Vice Chair, and Total Joint Replacement SIG Vice Chair. Nominations close on June 20th, with elections slated to open in August. See link in the show notes to find out more information. And now, back to the show.
We're at about time right now, and so it's the time of the podcast where we go into our rapid responses. So Fiona and Hannah, what we're going to do is we're going to put about a 1.5 minute timer, and between Danny and myself, Danny will take the first question and we'll direct it to Fiona. We will ask a question and it's a rapid response. So first thing that pops into your head, you go for it. Sound like a plan?
You ready?
All right,
Yeah.
Let me get my timer.
You tell me when you're up. I've got the first question ready.
All right, ready and go.
Does your current car have a name, and what is it?
I don't have a car.
Hannah, let's ask you the same question. Does your car have a name?
It's like a nickname. My color is Sporty Spice.
What's cool, awesome.
So great.
If Fiona, if you walked into a patient's room, what would your theme song be?
Oh, geez. I don't know.
What's on your playlist?
Literally.
Next, ask Hannah.
Okay. Is it the same question?
Yeah, same question.
Okay, maybe I'd go Boom Boom Pow by the Black Eyed Peas.
All right, okay, I like it. Go ahead, Danny.
New York style pizza or Chicago style pizza?
Come first. I can
Fiona.
go with Chicago, but like tavern style.
Tavern style. Ooh, okay.
I would say Chicago tavern or deep dish.
Very cool. Actually, this question will be for the both of you. Name a PT that's been influential in your PT career so far.
I mean, Sarah and Julia, RCIs from this past clinical, for
Very
sure.
Cool. Shout out to Sarah and Julia. Hannah?
I would say Dr. Jones, our neuro professor in our program.
Fantastic. What type of shoes do you wear on acute care?
I had Brooks.
Brooks.
I was in Hoka's.
Okay. Typical. And the final question, and you'll each take a stab at it. You know you are in acute care when?
I say your friends stop letting you talk about your day during dinner.
Right. Very good.
I would say when you're reorienting your patient, but you don't even know what day it is.
Right. That was me like last weekend, literally. Awesome.
Good
Well,
job.
Fiona-
Good job.
Fiona, thank you so much for being here today. Thank you for being guest on our podcast. And Danny, I want to thank you as well. Thank you so much for, having the opportunity to be able to have the conversation with you and engage in this conversation with Fiona and Hannah.
Thanks for letting me be a part of it. Nice to meet all of you.
Yes, nice to meet you. Thank you.
Yeah, thank you.
We would like to thank Fiona and Hannah for joining us on the podcast with one of our new co-hosts, Danny Young. Welcome, Danny. Acute Conversations is the official podcast of APTA Acute Care. This episode was hosted by Leo Regelis and Danny Young. Executive produced by Katie Brito and Edward Mathis. Music by Alexia Action from Pixabay, sound effects also from Pixabay. For more information about APTA Acute Care, be sure to check out our show notes for links and resources from the Academy. If you found value from our podcast, please be sure to subscribe, follow, and share with your friends and colleagues. Join us next time for an engaging conversation with soon-to-be new graduate Mika Mendoza. Thank you for listening, and may your shoes and scrubs stay clean today.